All right, let's get started for today. What is going on? How you guys doing? Hopefully you guys clicked on the new YouTube link on my bio. Check it out. I'm gonna be posting all these lives on there now. For anybody who's listening, it would be really meaningful to me if everybody can go check it out, subscribe to it. Let's spread this. Let's get radiology on the map. Let's finally get radiology out there. So for anybody's listening, please go subscribe and just go tell other people. We're doing this live pretty much every day. Yeah, let's get this going. So the question for today, I gave you that weird little image. Well, we started off actually in the beginning and we talked about, hey, appreciate it, man. We talked about in the beginning of the patient who's 50 something, whatever, jaundiced, or is itchy, that kind of patient. So everybody knows that kind of patient, and for those who don't, that basically means there's a backup of some sort of substance in the body. In particular, when we're talking about a jaundice patient or scleral icterus, it's yellow eyes, jaundice, yellow skin. They're gonna have pruritus, itchiness, other places. This is a liver patient, and the bile is not being excreted appropriately. So the bile, as you may know, it's gonna be all made in the liver, and then it's basically gonna go through the bile ducts. It can be stored in the gallbladder, and it's gonna go through the CBD, and it's gonna go into the duodenum, and it's gonna go out your bowel, and that's usually what bile does. So for the patient who has icterus, jaundice, all that good stuff, you have to figure out why. So you may be an internist, a family practitioner, surgeon, whatever reason, it's your job to get to the bottom line. Why is the patient jaundiced? The appropriate labs to order, you're gonna be looking for that T-bili is one. The T-bili may be elevated because it's not being excreted properly. Alkaline phosphatase is something else that will allow you to figure out that, hey, maybe something's obstructed somewhere. Maybe that's the cause of the patient's jaundice. You want to get some liver panel stuff as well. Obviously LFTs, AST, ALT, all that stuff may be elevated, and that can be acute hepatic inflammation causing the abnormality. So now you figured out, you did your job, you got the labs are abnormal, the T-bili's through the roof, the alkaline phosphatase is high as well. So now you got to figure out, well, why is the patient obstructed? Remember, alkaline phosphatase is high. I'm already thinking somebody's, he's obstructed somehow. So there's different routes that you can take. One, you can just go ahead, and what a lot of people will do, let's just talk about from the very beginning. If somebody didn't know the stepwise process of imaging to order, you may start off with an X-ray. You get a KUB, kidneys, ureters, bladder. That's literally what it stands for. So you get a KUB. You shoot the film. The patient still complaining of abdominal pain. The film shows absolutely nothing, because what is a KUB going to show? It basically shows it's really good for a bowel gas pattern, so it's going to show air because there's that high contrast between air and soft tissue, so it's really going to have that nice high contrast. So it's good for that. It's great for bones. You can see bones, whatever, depending on the penetration. If it's a super penetrated exam, you're going to see it down to the spine. If not so much, you may not see as much of the spine. What else is going to show? Calcifications. You may see a gallstone lodged in there. I had a case before. You may or may not remember a right lower quadrant circumscribed calcification in a young patient. It is diagnostic of appendicitis until proven otherwise. So that's just another side note, because I love going on side notes. So you did the KUB, it shows nothing. Your next step in imaging may be a right upper quadrant ultrasound. So you do the right upper quadrant ultrasound. It's cheap, it's easy, it's pretty fast. You can do it bedside if you want, if you're an ER physician, or if you're a resident up in the ICU, wherever. You can just slap an ultrasound on the right upper quadrant, and you can just evaluate what's going on with the liver. The liver may show signs of inflammation, very hard to tell off of ultrasound. Skilled people can tell it. You can go look this up if you want. It's called a starry sky appearance. It was more for an old school kind of ultrasound picture. That's one thing. the main thing you want to look for if you have this right upper quadrant ultrasound is, does the patient have biliary ductal dilatation, as we like to abbreviate it, BILDIL. So does the patient have BILDIL, and is it intrahepatic, extrahepatic, both, one or the other? You have to figure out which one it is. When I say intrahepatic, that literally means the hepatic, or the biliary ducts within the liver. If I'm talking extrahepatic, I'm talking about the common bile duct that's going from the liver to the duodenum. Remember, common bile duct, it's going to go from, all these biliary ducts are going to come together centrally, and then it's going to become the common bile duct, and then it's going to go dump into the duodenum. Okay, so remember that. Now, you did the right upper quadrant ultrasound. It shows biliary ductal dilatation. You know this guy's already obstructed, and you already had that suspicion because you saw the alkaline phosphatase was high, the T-bili was high, so you already knew in the back of your mind, you're like, yeah, this guy's obstructed somehow, whatever. The ultrasound pretty much further confirmed it, but the ultrasound didn't really give you an underlying etiology as to why. You saw that the intrahepatic ducts were dilated, you saw that the CBD was dilated and it measured up to, I don't know, let's give you a number, 1.1 centimeters. You may ask me, you're like, hey, Amrit, what is the normal CBD diameter? Normally, on a normal patient, normal healthy patient, I want it to be anywhere up to 6 millimeters, okay? So it can be 2 millimeters, 3 millimeters, whatever. It should be maximum up to 6 millimeters. Here are the caveats to this rule now. If the patient is post-cholecystectomy, gallbladder is removed, the CBD will dilate on its own, and that's totally okay. So in that sense, we say, you know, it's CBD is dilated, but it's tapering to the ampulla, and the ampulla is in the duodenum where it's going to connect. Remember I said CBD is going to go from the liver, it's going to curve around and go into the duodenum. So if you see this juicy CBD, but it's going nicely into the duodenum and the patient doesn't have a gallbladder, it's probably normal. Then you may ask, well, the patient does have a gallbladder, but the CBD is 8 millimeters. Then I'm going to ask you, how old is this patient? Only some of the few times that a radiologist care how old the patient is. So the person you're going to tell me, you're going to be like, oh, you know what, the patient's 82 years old. And you're going to say, you know what, I'm okay with that because this is the general rule of thumb. Obviously, there's exceptions to the rule, but general rule of thumb, if you're looking at a CBD, the patient's gallbladder is still there, and the CBD is, 8 millimeters, I'm going to allow you enough leeway that at 6 millimeters at 60 years old is normal. If it goes to 7 millimeters, but the patient's 70 years old, that's normal. If it goes to 8 millimeters and the patient's 80 years old, that's normal. So you can kind of see what I'm doing here, so and so, whatever. If somebody's 120, hey, more power to them. They're probably juicing, doing some celery juice. But that's the kind of general rule of thumb. So you have figured out, just to reiterate for anybody who's joining, I gave you that initial image. I said the patient's jaundice, he's icteric, he's itchy. You're already thinking something is obstructed. You're going to order the alkaline phosphatase, the chem panel, the liver function test, LFTs. You're going to see the T-bili is up, the alkaline phosphatase is up. Sure, AST, ALT is probably up too. Fine. Then you order the right upper quadrant ultrasound. You see these, 120, hell yeah. So you see the right upper quadrant ultrasound, you know the intrahepatic ducts are big, you know the CBD is big, but you know what, you're looking at it and you're like, the CBD did not go to the ampulla like Amrit told me it should. You're saying, you know what, it was okay if it was post-cholecystectomy and it was larger, but this guy had a gallbladder. And then you're also telling me, you know what, he's actually 42 years old, whatever I said 52 years old. He's 52 years old. He's not post-cholecystectomy. Why is the CBD so juicy? And it's actually not tapering to the ampulla like it should be. Now it's your job to figure out, okay, is this some sort of extrinsic compression or is this some sort of intrinsic blockage? You already see where I'm going with the intrinsic blockage part, because this is everybody's favorite thing to do, is to think about gallstones. So these gallstones are going to form somewhere. It's probably going to form in the gallbladder. It's going to go through the cystic duct. It's going to dump into the CBD, and then the stone is going to get lodged somewhere. Okay, it happens all the time. So now you're trying to figure out, well, it very well could be choledochal lithiasis. Remember, this is a very confusing word for me when I was in med school. I didn't know the difference between cholelithiasis, cholecystitis, choledochal lithiasis. They're all just very similar words that sounded very similar, and they kind of had the same meaning to me. So let's clear it up, okay? Lithiasis, anything that has lithiasis is stones. You can have nephrolithiasis, cholelithiasis. So remember, these are stones, okay? So if it's just lithiasis, nothing's infected. You obviously know, everybody knows what itis means, right? Itis is inflammation. So if you have cholecystitis, the chole part is the gallbladder. Chole and then cystitis, gallbladder's inflamed. Cholelithiasis, gallbladder has stones. Choledocholithiasis, I have no idea how to remember that. I don't have any fun little ways. Maybe choledocholithiasis is such a long word and the CBD is very long. I don't know. That may work for you. But that's basically a stone lodged down in the CBD. It's not sitting in the gallbladder anymore. It went through the cystic duct, went into the CBD, and it's lodged somewhere. Those stones, sure, they can be really tiny. They can go down into the CBD. They can go into the duodenum, and they just, out they go. You know how. But what if these stones are so big that they end up clogging up that CBD? Remember, it should go nicely, but then if you have a blockage right here before it goes into the duodenum, you're going to have this blockage and it's going to dilate everything up peripherally. So you ask me, is a right upper quadrant ultrasound good for that? Yes and no. If the stone is really big and the tech is really good at ultrasound, so you have to have kind of like the perfect storm, and you can probably see that stone, yes, that you may be able to catch it. Remember, real quick, I don't think we've gone over it yet. We will one day, but stones on ultrasound, you're going to have this echogenic line, which is basically the top of the stone, and then it's going to shadow underneath. So you have this echogenic line and then shadowing. Stones always have almost always have posterior acoustic shadowing, so remember that. So if your tech is really good, they scan the ampulla, they scan the CBD distally more towards the duodenum, they see this shadowing thing, all right, you're pretty much good to go. What if you don't see the stone? You're like, oh man, I thought it was choledocholithiasis, the long word, CBD long, remember that, so I don't know how you want to associate that. So you're like, I thought it was choledocholithiasis causing this obstruction. That's why the T-billing went up. That's why the alk phos was up. But you're like, no, it's not. So then what do? Order a CT scan? CT scan is not good at all for catching CBD stones. Not good at all. It actually misses a lot of gallbladder stones as well. Gallbladder stones are not always bright like you're expecting to see in like a kidney stone. Gallbladder stones are not always like that. We can look at a CT scan, the gallbladder will look completely normal. You can do an MRI and you will see this just densely packed with stones. So remember that CT scan is not the best for looking for stones. Sure, you're gonna do the CT scan, you want a quick, easy scan, you do it, you look, I'm just gonna read it off and I'm gonna say, hey, big CBD, patient has his gallbladder, so it shouldn't be naturally big. Patient's not old enough to have just a normally evolving, enlarging CBD. I'm gonna tell you, I'm gonna say, hey, CBD enlarged, I have no reason to suggest otherwise, I don't know what's going on. So then what's your next step? You have two forks in the road now, or one fork in the road to go two places. And this is another commonly, at least it was for me, you guys may be a lot smarter than I am. When I was in med school, I confused the words. I didn't know the word. I didn't even know the difference. ERCP and MRCP. Those are two very similar sounding acronyms, okay? How are you going to remember what is what? It's easy. MRCP. The CPs all canceled each other out, right? MRI. So MRICP. Just if you want to remember it like that, that's fine. MRICP. So MRCP. That is a sequence that we do on MRI. And that was the answer, by the way. That's what the sequence you were looking at. That was the study that I had posted. It was an MRCP. So Radiology 201, I don't know where my radiology resident colleagues are. For Radiology 201, what is an MRCP? It is a heavily T2 weighted sequence. If anybody tuned in yesterday, we talked about a T2 sequence briefly at the end when we were talking about the spine. I told you there's three things to look at if you want to figure out if it's a T2 weighted sequence. Anybody want to try to shout these out? And I'm gonna give them 5 seconds while I drink some water. We talked about it yesterday. All right, the three things that you should look at to figure out if it's a T2 weighted sequence. One is the CSF. The CSF should be bright. Number two is the gallbladder. The gallbladder should be bright. And number three is the actual bladder itself in the pelvis. That should be bright. If you see one of those three things, it's a 95% chance that you're looking at a T2 sequence. There's a little caveat to it. Nobody cares as far as, third, fourth year residents, radiology residents do, but don't worry about it. So 95% of the time, if you're looking at Any of those three things that are bright, it's a T2 weighted sequence. Going back to why I'm talking about T2 weighted sequence, because that's what an MRCP is. It's a heavily T2 weighted sequence. Therefore, anything that is fluid signal will be bright. Everything else will be saturated out. That's why you don't see fat. That's why you don't see liver parenchyma. That's why you don't see pancreas. You don't see anything else except for anything that is like simple fluid. So here we go. That was an MRCP. That's what I had showed you guys for that image. Here's the fork in the road. I described this fork in the road. I'm not gonna flip you guys off, but that's the other one right here. That's an ERCP. ERCP is something that a gastroenterologist does, okay? What they're gonna do is get a scope, go down into the mouth, into the esophagus. They're gonna bring the scope down through the stomach, past the pylorus, into the duodenum. They're gonna pop out of the ampulla, and then they're gonna get into the CBD. So they get into the CBD, and this is all through a scope. They're visualizing it all as they do it. And then they're going to basically get a wire and a catheter into the CBD, and then they're going to opacify it. They're going to inject contrast, and then the CBD is going to light up, and then they're going to see filling defects wherever stones are, or they're going to show external compression if there's a mass externally. They can also get into the pancreatic duct as well and do the same thing. That is an ERCP, which was this one. MRCP is an MRI sequence. Once again, remember, MRICP is this one, ERCP is this one. Now you're going to ask which one, and it's kind of intuitive once you actually get the hang of it. MRCP is only diagnostic. ERCP is diagnostic and therapeutic. Not only can they diagnose what's going on with the CBD or pancreatic duct, but they can also fix it. MRCP, all I can do is tell you what's going on with the duct. Woo, that was a lot of information. Are you guys with me? So which one did I gave you guys this one here. So I posted this one here to you guys in the morning. And I said, first of all, let's figure out, we know that this is obstructed, okay? How do we know that? Because this is what a normal should look like. This is normal. Here's your gallbladder, nice, beautiful gallbladder. This is your common bile duct right here, beautiful, it branches, perfect. This is your pancreatic duct right here. This is normal, normal, normal. And then it's gonna go and it goes, goes, goes. Here's the ampulla. This is gonna be the duodenum. It's gonna be coming in like this, okay? Remember, I always do this when I say duodenum because it makes a C shape. This is normal. Ingrain that. Let me zoom out here manually. Ingrain that into your head. This is normal. This is what I gave you. Is this normal? Absolutely not. Here's your pancreatic duct. That's not bad. I don't mind the pancreatic duct. Look at this bad boy. This is ballooned up. Intrahepatically, it's ballooned up. Extrahepatically, it's ballooned up. It does not look like this guy right here. All right, so now you're going down. All right, I have to figure out, you're going down the road of what's causing this obstruction. Do you think it is an intrinsic obstruction? Do you think it's a stone? Or do you think it's an external compression? Great questions. You can also go down the congenital route. We can do that some other time, but there's something called choledochal cysts. That's a whole different ballgame. But still, that should go to the ampulla of the duodenum. You should still see it connect into the duodenum. This guy, I didn't see it connect. So let's talk about it. Choledochal lithiasis very well could be a differential on here. Absolutely. This could be choledochal lithiasis. What is the second thing that it could be? You can never rule out malignancy. Malignancy, malignancy, malignancy. If you're thinking about LFTs that are high, if you're thinking about alk phos that's high, T-bili is high, don't ever rule out malignancy until you've done enough appropriate workup. You can go work out too if you want. So malignancy, and let's talk about real quick, what kind of malignancy can grow in this area to cause the CBD to dilate up? It's a term, it's a malignancy that not many people, I didn't hear about it really when I was in med school. It took me a little while actually in residency when I figured out. Cholangiocarcinoma. Cholangiocarcinoma is a malignancy of the bile ducts. There's two different types. We'll talk about the one that is a malignancy of the bile ducts. So it's actually malignancy that grows into the duct and it squeezes that duct. It could be a common bile duct or it could be just a focal area in the liver itself. So if you ever open up a scan and you just see this focal area, maybe like, segment 6, segment 4, whatever it is, and all you just see is this just focal area of dilated bile ducts, be very concerned about cholangiocarcinoma. It loves to constrict those things. It also loves to grow where the CBD meets the duodenum or anywhere along the trajectory of the CBD. Remember, in my little imaginary drawing, this is the liver, this is the CBD, and this is the duodenum. So it loves to grow along this path right here. So if you ever see a ballooned up CBD and it's going, and then it just pinches off like that, be very concerned that cholangiocarcinoma has grown into it and it's caused that obstruction. That's number one. Let's talk about now, just to reiterate for anybody who joined, this is normal. Nice normal gallbladder, nice normal CBD, nice normal pancreatic duct. Both of these guys are meeting into the duodenum. I do my little C thing, that's where the duodenum would be right there. This is what I gave you, abnormal. Here's the other one that I want you to differentiate. I'm gonna give you 2 seconds before I start talking some more. Tell me what the difference is in this one compared to the one that I just showed you. All right, so we see the CBD. These are massively dilated. These intrahepatic ducts are massively dilated. The CBD is kind of doing this little corkscrew thing. And it's going. It comes to a point right here and it's gone. Look at this pancreatic duct. This is nasty. This is a nasty pancreatic duct. This is massive. Once again, compare it. That's normal. That's flagrantly abnormal. Just me as a radiologist, me looking at this and me looking at this, I'm telling you immediately what cancer I'm concerned for here and what cancer I'm concerned for over there. So what kind of cancer can grow here centrally to cause the pancreatic duct to dilate and to cause the CBD to dilate? This is what pancreatic adenocarcinoma loves to do. It grows just like I told you cholangiocarcinoma grows in the bile ducts over there. Pancreatic ductal adenocarcinoma loves to grow into the pancreatic duct. So not just how cholangio over there cut off the CBD and it ballooned it up. That's what pancreatic adeno-CA does over here. It's going to constrict off that pancreatic duct, and then it's going to balloon this wide open. This thing is so ballooned up that, can you see these little radiations coming off the pancreatic duct? Those are little outpouchings because there's so much buildup back pressure that it's popped out in those little areas to try to alleviate the pressure in the main PD. Pancreatic adeno-CA, cholangiocarcinoma, normal. All right, so that's the difference of these 3 different things, okay? What else can we talk about? You can ask me how can we relieve, so let's talk about temporary relief of these symptoms. So if the patient comes in, jaundiced, yellow skin, scleral icterus, yellow eyes, itchiness everywhere, their stools, I forgot what it was, USMLE step 1, somebody, med student, help me out. It was like oily stools or something like that, I forgot what it was. If they have all those symptoms and you get this imaging, remember my bifurcation, MRCP, ERCP. MRCP, I diagnosed it. By the way, our MRCP, at least in our institution, when somebody orders an MRCP, we get the whole MRI as well. All the contrast enhancements. So I'll tell you exactly the contrast enhancement pattern. Radiology 401, for anybody who's interested. Steateria, thank you so much. Radiology 401, for anybody who is interested, the enhancement pattern of cholangiocarcinoma is the same as adenocarcinoma. Why? Because they're pretty much the same actually type of cancer. Cholangiocarcinoma in some institutions, the pathologist will call it a pancreatico-biliary carcinoma. They can't really differentiate if it's pancreatic adeno or if it's CBD cholangiocarcinoma. So the enhancement pattern is the same. What is that enhancement pattern you're about to ask me? It's delayed enhancement. So you have a delayed enhancement. It's kind of like this fibrotic tissue. On MRI, even on CT scan, fibrosis loves to pick up delayed enhancement because it just takes forever for that contrast to get into that fibrotic kind of type of material. So delayed enhancement for both of those cancers. I went on that tangent. Where was I before? Somebody just asked a question. Could gallstone pancreatitis cause a dilated pancreatic duct also? Absolutely. Yes, gallstone pancreatitis, you'll have the alk phos up, you'll have all the enzymes up, all that good stuff, and then the stone will be lodged. It will cause a pancreatitis, and it will cause the backup, cause a dilated, oh, you said dilated pancreatic duct. Yes. Yeah, that's a good question. You can have, this is a good question, it'll go onto a little tangent real quick, that patients with chronic pancreatitis, if you're ever reading a CT scan and somebody has chronic pancreatitis, they'll have calcifications studded throughout the pancreas. Be very careful for any radiology residents who are listening right now. Make sure those stones are actually in the pancreatic parenchyma and not actually intraductal. If that stone is in the pancreatic duct, that's the cause of the patient's pancreatitis. Patients come in sometimes and they are in their progress notes and their H&Ps everywhere. It says chronic pancreatitis. Patients probably drinking a bunch. They're denying it every single time. The patient's like, I'm not drunk. I keep getting pancreatitis though. You're like, yeah, I don't really believe you. It's obviously not a scorpion bite. I love step one question right there. It's not a scorpion bite. Be very careful. That's not actually a stone in the duct of the pancreas or the pancreatic duct causing that chronic pancreatitis. So that's my little side note. Going back to, the treatment for this. So you want to get the patient out of the acute symptoms of his jaundice, all that good stuff. You want to bring that T-bili down. You want to bring that alk phos down. You want to build a hepatic inflammation, bring that all down as well. So to bring them out of the acute phase, 2 avenues that you can do. Let's kind of use the same little fork in the road. MRCP is the radiologist route. ERCP is the GI route. So you have 2 different routes you can do, okay? Go to the radiologist route, just saying. So what can IR do about this? What we can do is we can get the patient down into the angio suite. I'm going to look with the ultrasound and I'm going to find that dilated duct, okay? And then with the ultrasound, I'm going to give lidocaine, do all that stuff, whatever, sterile prep, blah, blah, blah. That's not blah, blah, blah. That's important. We don't want them to get infected. So when I get the ultrasound, I find that dilated duct, and I'm going to shove a 22 gauge needle all the way down into that bile duct, okay? I'm going to target it, I'm going to get into it, and then I'm going to pacify the system. I'm going to pacify it with contrast. So it's going to be all lit up now, and I'm doing this at the same time that I have fluoroscopy overhead as well. So not only was I looking with the ultrasound, I have fluoro pacifying that system now. So it's now like what we call a percutaneous transhepatic cholangiography, PTC. So I got that PTC. It's going to show me the exact same thing as what the MRCP did, right? And actually, it's going to show me the same thing that the gastroenterologist did with the ERCP, but they went through the esophagus, through the stomach, into the duodenum, and then pooched out and then opacified intraductal. What I did is percutaneous. I got a needle and went through into the bile duct, and then I injected contrast. Fun little fact for any IRs out there, what can happen, what is negative adverse effect of opacifying the biliary system that's obstructed too much? The patient can go into Rigers real quick. You make sure you want to give them some prophylactic antibiotics before you do this. All right, so I pacified the system percutaneously. Don't worry about some other steps. We can talk about it some other time. But I'm going to get a drain into there. So now I got a percutaneous biliary drain. That's going to be into the bile duct. Let's use this for example. Say I got the biliary drain right here. It's going to be a little pigtail catheter. And then it's going to come out, and go into here. And then it's going to go out the skin like that. So now I got this biliary drain in place. And then now the bile, instead of going naturally into the duodenum, which would be here, now it's going to go out the bag and or out the tube and go into a bag that's sitting on top of the patient's stomach or wherever we taped it. So that's one thing that we can do. What else? ERC, let's stick with what IR can do. So we're still with this finger right here, right? So what else can IR do? Not only can we drop that drain in place, we can actually stent it inside as well. We can use a catheter. It will be an internal external drain. So not only will a pigtail be right here, there'll be a portion of the catheter that's right here. Not only will it come out the patient here, but a portion of it will actually go internally. We'll get past the obstruction, and then we'll drop the other portion of the pigtail catheter in the duodenum. So that's called an internal external drain. So you have just an external drain, which is just draining out the patient, or there's an internal external drain that can drain outside the patient as well as naturally draining into the duodenum. We can also drop metallic stents in there as well. That's more of an end stage patient. You don't want a metallic stent in a patient if a patient's going to be around for years and years and years. So that was MRCP, radiology, IR. This is ERCP, gastroenterology. What can they do? Pretty much the same thing as far as stenting internally. So they can drop a stent, a plastic one or a catheter type of stent into the CBD, or they can drop a metallic stent as well. They can't do anything as far as putting a percutaneous drain because they can't go from inside out, but we can go from outside in. So that's the fork in the road. That's the difference between these two. Whew, that was a lot of talking. Somebody asked a question. What do you guys got? Did I want to cover anything else? Oh, let's cover real quick. Anybody ever heard of the word Mirizzi syndrome? Anybody heard of that? Mirizzi syndrome. Do I have a good... Yeah, I kind of do here. So this is normal. Remember this. Ingrain this into your head. This is stone cold normal. Pancreatic duct going beautifully, beautifully, beautifully to the CBD. This is the CBD coming beautifully into the duodenum. Remember, this is the duodenum. This is how they're going to insert in. And if you look at the gallbladder, this is the gallbladder. If you can kind of humor me here a little, do you see this little wisp? That's the cystic duct. So the cystic duct, and then it dumps into the CBD, and then both of them go into the duodenum. So Mirizzi syndrome, let's go back here. Mirizzi syndrome is if you had a bunch of stones in here, and then you just had this big hunking stone that got lodged into this cystic duct. It was so big and it had so much mass effect on the adjacent structures that it actually cut off the CBD. So there's this big thing that just occluded the CBD. So you need to be very careful, and you need to tell the surgeon, hey, this is not actually an intra-CBD stone that's causing the CBD to be cut off. This is actually a stone in the cystic duct that has so much mass effect that is pushing against the CBD, cutting the CBD off. That's a random side note. Ooh, what else? What else you guys got for me? Anybody want to radiology? I don't know, what is this, 301 now? Cholangiocarcinoma. Remember I said there's two different types. There's one type that grows into the ducts. There's another type that can just be kind of like a mass in the lesion or in the liver or anything. The other fancy word that you're going to hear, oh man, you beat me to it. Chronicles of a medical nerd. Claskin tumor. Kudos to you, man. Or woman. Sorry. So Claskin tumor, that is a cholangiocarcinoma in the hilum of the liver. So it's going to cause, remember I told you, a notorious sign of cholangiocarcinoma is if you open up a CT scan or an MRI and you see this focally dilated area of biliary ducts, worry about cholangiocarcinoma. But what happens if you see this? What happens if you don't even see this CBD, but you just see these massively dilated intrahepatic ducts, and they all look like they come to a little point and none of that CBD is present at all? That's what you got to worry about, a Claskin tumor. It is a cholangiocarcinoma sitting right at the hilum where all the biliary ducts come together, and it just cuts them all off. So then there's just, it looks like this just like huge tree of vessels, or sorry, ducts intrahepatically. So that's just a fancy word that you may come across in your rotations, wherever. Ricardo, hello. What's up? Igor joined. What's up, man? What else do you guys got? Did I miss any questions up top? Whoo, talking about that. God, sometimes I feel like I'm just rambling. My bad if I am. Anybody want to know anything else about MRCP? I think we pretty much covered it all. IR, anybody, if anybody's wanting to know about the IR other aspects of this, say I put an internal external drain in. Remember, that's a drain that's going not only into here, and it's going to drain externally from the patient, but it's also going to go, we're going to get past this occlusion, get into the duodenum, and I'm going to drop the other end of the drain in there. So that's an external internal drain. So what's going to happen? I'm going to eventually, I want the patient to drain internally normally. I want him to do that, okay? So I'm going to allow it to drain externally for a little while. I'm going to allow it to go into the bag that's sitting on top of the patient for a while. I'm going to allow that inflammation inside the body to decrease. This can happen with pancreatitis too, by the way, when pancreatitis just gets nasty. So I'm going to allow all that to kind of heal up a little bit, whatever. Maybe let the chemotherapy do its thing. And then I'm going to do a capping trial. So a capping trial is literally, I'm going to take the bag that's on the catheter that's sticking out the patient. I'm going to take the bag off, and I'm going to screw a little cap on. What is that going to do? That's going to, so whatever fluid or whatever is going to go to the path of least resistance, okay? That's just medicine. You want to go to the path of least resistance. If there's a lot of resistance going into the duodenum, well, then it's going to want to go out the back. If that resistance has resolved, well, then it's going to want to go into the duodenum. So that's a capping trial. So if I screw that cap on, The patient goes home. He comes to me the next day and he's like, no, it's totally fine. I have no issues at all. I'm like, oh, all right, we're good, we're good. If I put that cap on and that patient gets rigors, febrile, he's whatever, all that good stuff, well, then that capping trial didn't work. He failed that capping trial. Then that bile is not excreting normally into the duodenum, and it's trying to go to the path of least resistance, which is out the tube, but I capped it. So you have to immediately uncap it. You have to go back to the bag, and you have to wait around until he may need to have another capping trial. That's what we do with internal-external drains. Boo. What else? Anything else I want? This is all top of my dome right now. Anything else that I want to cover with you guys regarding MRCP? I don't think so. I don't think so. That was all the high notes. Just to reiterate, last time, if you see this, if you see the PD's huge and you see the CBD's huge, both of those together, be very concerned for a pancreatic ductal adenocarcinoma. If you see just the CBD big and the pancreatic duct is normal, be concerned about either a choledochal lithiasis or cholangiocarcinoma. If you see this, send the patient home because this is stone cold normal. All right, let's go. Any other questions before we call this? All right, I think we're good. This is gonna go on to YouTube right after this. And difference between MRCP and PCI? What do you mean by PCI? All right, this is gonna go up on YouTube after this. The link is in my bio. Check it out, please. I appreciate you guys. Seriously, this is becoming a thing. I love this. I love doing this. I love teaching you guys. I love going over stuff. I love the questions. Let's keep doing this. If you guys can please go out there, tell somebody that you need to really check out this YouTube channel because it's freaking awesome. Thank you guys. We'll pick this up. I'll have case of the day tomorrow and we'll go over it again. I appreciate y'all. Peace.